Welcome to Lunchtime Live at the Center, where we talk about important fertility-related topics to inform and support your journey. My name is Ami Choksi, and I am your host. Now, in our clinic, we recommend and offer several diagnostic tests to help us determine the best approach to your treatment plan. And today, we have Dr. Lawrence Engmann, who is here to talk about them. Now, Dr. Engmann is a lead physician at the center. He's been with the center since 2006. And he's also an associate professor in the Department of Obstetrics and Gynecology at UConn Health. Dr. Engmann, welcome.
Thank you. Thank you very much for having me.
Yeah. No two individuals are the same. So we have specific tests that we use to develop and personalize a treatment plan. And they include both blood tests as well as physical in-person ones. Could we start with, could we talk a little bit first about the blood tests that we do, like day 3 blood work?
So that's a good question, and it's a good point to know that no two individuals are the same, and therefore the essence of the initial appointment is to take a history and go delve into the medical history and figure out what's going on. And then at the end of the history, we typically will do an pelvic exam and then do some blood work. And one of the blood works that we do is the day 3, what we call the day 3 blood work. And it's done on the 3rd day of the period. And it consists of FSH, LH, and estradiol. Now, these are hormones which are released from the brain, and typically the FSH is supposed to stimulate the follicles within the ovary to develop. And if you have a lot of eggs within the ovary, the FSH level is low. If you do not, then the FSH level is high. So it's like the brain, if you don't have a lot of eggs, the brain is telling the ovary to produce more FSH, and therefore typically is used to assess what we call ovarian reserve. So to assess the pool of eggs within the ovaries. And so we recommend that it's done on the 3rd day of the period.
So, and what if you have the wrong days? Can it be done on the 2nd or the 4th day?
That's an excellent question, and that's something that we encounter all the time. When do I have the test done? Is the 4th day okay? Is the 5th day okay? No, it's not. Now, we usually recommend that patients go on the 2nd or the 3rd day, not the 4th day.
Okay.
So usually, and the other question is, when do I start counting? Is it the beginning of spotting or is it full flow? And we recommend the 1st day of full flow as day 1, and then go to the lab on day 3. And typically, most labs are opened Monday to Saturday. So we recommend that if day 3 happens to be a Sunday, then you go on Saturday. So day 2 or day 3 is the best time to have it done. And the reason is that that's the baseline. So that's when everything is quiet. If you go on day 4, the brain would have started producing a lot of FSH to stimulate the follicles or the eggs within the ovary to develop. So it will be artificially high, which will be wrong. So we want it at baseline, which is the 2nd or 3rd day of the period.
Is this only for new patients, or is this also for, is this an ongoing test?
Typically, we do it for new patients, but we tend to repeat it every year. Mm-hmm. Because one may expect that things may change over a year. So we repeat it after a year.
And these are 3 that you test. Are there other are there other tests that require a blood test? Are there other diagnostic tests that require blood tests, that is?
Yeah, so at the initial appointment, the other test that we will recommend that you do will be AMH. So AMH is not really time sensitive, so it can be done anytime during the cycle.
Okay.
But in the past, when we see patients in the office, we do most of the blood work that day, which is not time sensitive. And then when they have the period, they go to the lab on the 3rd day. But with COVID, now we're doing telehealth. And so most patients would do all the blood work on day 3 or day 2, so that they don't have to go twice to the lab to have the blood work done. But AMH is another hormone which is used to determine ovarian reserve, to determine the number of eggs remaining within the ovary. It's not necessarily the number of eggs, but the pool of eggs, whether you have enough eggs within the ovary or not. And it's produced from the ovary. It's produced from cells that surround the follicle. So the follicles are fluid-filled sacs within the ovary, and within the follicles are the eggs. So if you have a lot of follicles or a lot of eggs, then the ovary produces more AMH. If you don't, then the AMH level is low. And therefore, measuring the AMH tells us whether you have a lot of eggs or not, which is an important test which helps us to determine the likelihood that you're going to respond well with stimulation.
So how is FSH, so you had mentioned ovarian reserve with FSH as well as AMH. So how are those two, what is the difference between those two?
Oh, excellent. That's a very good question. So AMH is thought to be more sensitive to assess ovarian reserve. It's unlikely to fluctuate throughout the cycle or in between cycles, and it's unlikely to be affected by several other things. Although we know that things like being on the birth control pill will suppress AMH levels, but most of the time it's supposed to be fairly stable. However, FSH varies from cycle to cycle. So you may have a high FSH this month, and the following month when you repeat it, it may be normal. So it's not as sensitive as AMH. Okay. But they both do the same thing. So if the FSH is low, it means you have a lot of eggs. If it's high, it means you don't have a lot of eggs. If the AMH is low, so it's opposite with AMH. If AMH is low, it means you don't have a lot of eggs. If it's high, it means you have a lot of eggs. So they complement each other.
Okay. Now, how does AMH affect, does a low AMH affect your ability to get pregnant or to conceive?
That's an excellent question, and we get asked that all the time. I think it's important to realize that a lot of the tests, research that has been done with AMH is in relationship to whether someone is going to respond well to medications or not. So let's say if we do AMH on somebody walking around, not even trying to get pregnant, and it's low, and or just started to get pregnant, it doesn't necessarily mean that she's not going to get pregnant. It just means that if we do stimulate with fertility medications, the likelihood that she will respond well to medications is low. And it's being used to correlate with pregnancy as well. However, the main essence of doing that, the test, is to determine whether you have a lot of eggs within the ovary. And what I usually explain is that everybody's born with a number of eggs, and over the years, the number of eggs tend to diminish. Now, the period of time at which this happens really varies, but typically we know that around 37 years of age, the number of eggs starts to gradually decline. But this is different for everybody. Everybody's different. In some women, even around the 20s, the AMH level may be low because the number of eggs at that time may have already declined. So it's very variable. The other important thing is that it's possible that AMH may be low for a very long time. We don't know how many years. I've had patients who have had 3 children with low AMH. So it's possible it may be low for a long time. However, when we see women who are trying to get pregnant and are having difficulties, it's difficult to tell where are we in that time span. Is it the beginning? Is it in the middle? Or is it in the end? So at times we may recommend to our patients to be a little bit more aggressive if their AMH level is low. But it does not necessarily predict the probability that they're going to get pregnant. And I think that's an important point to understand.
So low AMH doesn't mean an infertility sentence. It just helps you manage their treatment plan.
Yes.
Okay, Great. Now, are there other blood tests that you do, like thyroid and vitamin D?
Yes, so that's also a very good question. So thyroid is important. Now, if thyroid is low, or if the thyroid level is high, which means that the thyroid is functioning suboptimally, then that could result in an increased risk of miscarriage. If it's very abnormal, then patients may not ovulate at all and may not be releasing eggs. So it's important to check the level so we know where it is. If it's abnormal, we will usually correct it. We will usually give supplementation to prevent the risk of miscarriage when patients get pregnant. The other test we do is vitamin D, which is also very important. There's been so many studies done regarding vitamin D and pregnancy. And there are studies that suggest that if the vitamin D level is low, then the pregnancy rate may be low and the miscarriage rate may be high. And also in women with PCOS, it's been shown that it may affect ovulation as well. So it's important to control the vitamin D levels during the evaluation of infertility.
What levels are you looking for when it comes to vitamin D?
So vitamin D, the normal level is 30. Between less than 20, it's significantly abnormal. 20 to 30 is will need some form of supplementation. So typically it has to be over 30.
Okay.
Between 20 to 30, we recommend that patients go on vitamin D3, 2,000 units every day, which you can get over the counter. If it's less than 20, then we recommend about 50,000 units weekly for about 8 weeks, and then supplementation with 2,000 units every day.
And when it comes to thyroid, are you looking at TSH, or is there any other level that you're looking at?
That's an excellent question. Now, the initial assessment is TSH. And for the general population, the level that you need is around 4 or so, anything less than 4. But for women who are trying to get pregnant, we want it to be less than 2.5. It's been shown that if it's over 2.5, it may increase the risk of miscarriage. So what we tend to do is, if the initial level is low or is high, then we will repeat it. And then we will add free T4, which is actually the circulating thyroid hormone. Okay. Because the TSH, and this gets a little bit confusing for patients, the TSH is released from the brain, and that's what stimulates the thyroid gland to produce the thyroid hormone. Now, if the thyroid gland is not functioning normally, then the brain produces more TSH. So a high TSH means that the thyroid is not functioning appropriately. So when we do the further testing, we actually measure the thyroid hormone itself, as well as a repeat TSH. And then we measure thyroid antibodies as well. Because at times the TSH may be normal, but the thyroid antibodies may be low, may be high. And in such situations, it's possible that the patient may have abnormal thyroid function during pregnancy, and therefore we may tend to repeat it. Even if we don't start on medications, we may tend to repeat it during pregnancy.
Okay, thank you. So let's move over from blood work to in-person physical physical exam tests. Starting with an ultrasound. New patients have to come in and do an ultrasound. And what would that entail, and what does that test for?
So that's excellent. In the past, before COVID, we would do the pelvic ultrasound the same day as a new patient visit. But now with COVID, with doing telehealth, we do the pelvic ultrasound at a separate appointment. Okay. The pelvic ultrasound is to assess the uterus and the ovaries. If you remember from biology days in high school, when you're trying to get pregnant, you need the sperms are deposited in the vagina. It moves through the uterus into the tubes, and then the egg is released from the ovary, and then it's picked up by the tube and fertilized in the tube, and then the fertilized egg goes into the uterus and implants. Now, it's important for us to try and make sure that all these are functioning properly. So when we do the ultrasound, we're looking at the uterus, and we're looking for any abnormalities such as a fibroid. A fibroid is a benign growth of the wall of the uterus.
Okay.
We're looking for polyps. Polyps are also benign growths of the lining of the uterus. And then we look at the ovaries as well. Are there any cysts? Is there anything on the ovary that could potentially affect pregnancy? And then we count the number of what we call antral follicles. So those are small follicles within the ovaries that have just been recruited. And that could be correlated with ovarian reserve as well. So we want to make sure that there's, in addition to the FSH and the AMH, there's also a good antral follicle count, which will help us to determine whether the ovarian reserve is normal. And we want to make sure that are there any cysts such as endometrioma. So endometrioma is endometriosis of the ovary. It's a cystic fluid of endometriosis in the ovary. And the lining of the uterus is called endometrium. When it's found outside the body, it's called endometriosis. If it's found in the ovary with a collection of fluid, it's called endometrioma, and that could potentially affect the chances of getting pregnant.
And is this to check the antral follicle count? Does that need to be on a specific day of a cycle, of a person's cycle?
You know, ideally, based on all this research that has been done, ideally is usually early part of the cycle around day 3, day 2 or day 3, but it doesn't necessarily have to be so. So if we do the pelvic ultrasound at any time during the cycle, and the antral follicle count on those days, it's also fairly well correlated with the antral follicle counts at baseline.
Okay. Now, moving to HSG, and what is the HSG?
So the HSG is a dye test of the uterus. It's an X-ray dye test of the fallopian tube. And as I mentioned initially, you need the tubes for the eggs to be picked up and for the eggs to be fertilized. Mm-hmm. So the HSG is basically called Hysterosalpingogram. We put a contrast media in the uterus, and then take an X-ray to look at the inside of the uterus, but most importantly, to look at the fallopian tubes and make sure that the fallopian tubes are patent, that is, they are open and they are not blocked at the end. So basically that's, and you cannot see the fallopian tube on ultrasound. So that's why we do the HSG, to be able to determine whether it's open or not.
Okay, so this is to see if the tubes are open and you can see this. Is it painful?
That's an excellent question, and I usually tell my patients don't go online and read because those people who do that come in very anxious, because especially those who have had worse experiences are the ones who will most likely put something online. But it's usually you may have some cramping, and most people describe it as a menstrual type cramping. We usually encourage our patients to take some form of analgesia, such as Motrin, Aleve, or ibuprofen an hour before to help with the cramping.
Okay.
I can tell you that about 95% of patients do well with it.
Okay. And is it possible that this test could actually help open up fallopian tubes?
Yeah, that's a very good question, and that's the old adage. Is it when you do the HSG, is there an increased probability of pregnancy? Theoretically, yes. So let's say if you just have a mucus plug around the opening to the tube, then when you do the HSG, you just flash that mucus plug out and open the tube. There are some studies that have suggested that there is an increased pregnancy rate just after doing an HSG. And anecdotally, I've had patients who have gotten pregnant after having the HSG done. However, it's not a form of treatment. It's a diagnostic tool. And at times, some patients get pregnant after the HSG.
Does everyone have to have it?
Not necessarily, no. So if, let's say, at the initial consultation, the reason for the infertility is male factor, and so there's a problem with the sperm, and we're going to do IVF, and there's no risk factor for having a tubal disease, then we don't do HSG. We'll do something else called sonohysterogram to evaluate the uterine cavity. So if you're going to do IVF, it's not necessary.
Okay. So speaking of sonohysterogram, could you talk a little bit about what that involves then?
Okay. So sonohysterogram is a saline ultrasound. So basically what we do is we put in saline into the uterine cavity, and then we do an ultrasound. What it does is it distends the uterine cavity. So if there's anything inside the cavity, such as a polyp or a fibroid, that could reduce the chances of getting pregnant, then we will be able to see it. So a polyp is a growth of the lining of the uterus. It's a benign growth. And if you have a polyp, it could reduce the chances of conception. So usually we will recommend that the polyp is taken out before doing any form of treatment. The other thing that we could find is a fibroid. So fibroid is a benign growth of the wall of the uterus, and at times it may impinge onto the cavity. Okay. And therefore affect the chances of implantation. And therefore, if you have a fibroid which is going into the cavity, then we will need to remove it before doing any form of treatment. The other thing we can find is scar tissue, adhesions within the cavity. If we do a saline ultrasound, we can see scar tissue within the cavity.
So do you need, could someone, is it either or HSG or sonohysterogram, or are there some people who would require both?
For the most part, no. So for a new patient who is having an initial evaluation, the HSG is more than adequate, because the HSG could also evaluate the uterine cavity. It's not as good as the saline ultrasound, but the HSG is to evaluate the cavity and the tubes. So if that is normal, and let's say semen analysis is normal and everything else is normal, and you're maybe going to start with a treatment such as intrauterine insemination, you do not need to do a saline ultrasound. However, if let's say we did the HSG and we find something suspicious, like a polyp, something may be in there and we're not sure, then we would do the saline ultrasound to delineate the cavity so we can see, and then we can remove it. But for the most part, no. Okay. For those doing IVF, if the saline ultrasound is normal and there's no risk factors, then they don't need to have an HSG as well.
Okay. And, is this done in the office, or is it?
Yeah. So both tests are done in the office. The saline ultrasound is done in our usual exam rooms where we have ultrasounds. The HSG, we have a special room, a small room that has the HSG machine there, and that's where we do it. So it's done in our office.
Okay. In a previous live, we've talked a little bit about carrier screening. So what is the role of carrier screening in diagnosing some fertility issues?
So that's an excellent question. So when we see patients for their initial consult, it is an opportune time for preconception counseling as well. So it's important to determine that there's nothing that could affect the baby. So carrier screening involves testing for genetic diseases, such as cystic fibrosis. So cystic fibrosis is a genetic disease, and the children tend to die at a young age from chronic lung diseases. And you need both parents to be carriers to pass it on to your child. So if, let's say, both parents are carriers, there's a 1 in 4 probability that the child may inherit the disease, and it could be serious. And so it's important to be able to pick it up before they even try and get pregnant, because there are decisions that can be made before conception occurs. So let's say both are carriers, and they could do pre-implantation genetic testing to test the embryo to make sure that it does not have the gene before it's transferred. If only one is a carrier, one parent is a carrier, then it becomes a moot point, because worst case scenario, one of the children may just be a carrier, just like one of the parents. But it's not only cystic fibrosis. There are several other genetic diseases out there, such as Fragile X. So Fragile X, if let's say the mother has Fragile X and passes on to the child, it could actually become worse. And it could result in premature menopause. It could result in learning disabilities. And then there are other things such as SMA, which is spinal muscular atrophy, but that's about over 170 genes that we test for. And it's important to do it before conception. If you don't, alternatively, you get pregnant, and when you see your OBGYN, the test is performed, and then if both of you are carriers, then you have some difficult decisions to make in terms of testing the baby and making some tough decisions. So that's why we do it before conception.
And we talked a little bit about if there's male factor. So is there also testing that we do for men as well?
Yes, we do. And the men don't go scot-free. So they do semen analysis. So they produce a semen sample. And then basically what we do is we do the sperm count. So we count the number of sperms. And then we look at the proportion of sperms progressively moving forward. And then we look at the shape of the sperm.
Okay.
Because it's important. If the sperm count is very low, then it will reduce the chances of getting pregnant. Or if the sperms are not moving forward as they should, then they wouldn't fertilize the egg. Or if there's a lot of abnormally shaped sperm, then fertilization will not occur. So yes, we require semen analysis.
Okay. Dr. Engmann, this has been really helpful. We have time for maybe one personal question. Yeah. What is the best advice you've ever received?
Well, the best advice I received was from my mom. She said, love everybody just like yourself. The good old adage, love thy neighbor as yourself, and love them unconditionally. Mm-hmm. And she also said to me that respect everybody, regardless of who they are. Just treat them like you would treat yourself. And the third thing she told me was work hard. Be the hardest person in the room. So I live by that every day. I love everybody just like I'll love myself. I respect everybody just like I'll respect myself. And I do my best to work very hard.
Those are great words of advice from your mom.
Yeah.
All right, Dr. Engmann, thank you. It's always nice talking to you. And we will be back next week for another Lunchtime Live. Be sure to check out our website as well at UConnfertility.com for additional information and a calendar of events to support you and help you feel connected. So see you next week.
Thank you very much for having me. Take care.
Bye.